I present to you none other than Dr. Barney Graham.
Good morning, and thank you for the chance to talk with you all today. In order to keep this under control, my granddaughter wanted to say a word just before we started, so here she is.
My name's Anaya, and this is my grandpa, and we both figured out coronavirus.
Okay, all right. So that is Anaya. She's a budding new virologist,
And I'm
and you're five. She's 5 years old, and I wanted to do that in part because even though I'm a scientist and physician, I am worried about the same things all of you are worried about, and that is how to protect our families and each other. So I'm going to tell a little bit about the backstory of the development of this coronavirus vaccine and why it's important to go fast and how we were able to go so fast. And then maybe we can answer some questions about your other concerns. So this is an illustration of the deadliest pandemics in human history. And most of these have been caused by bacterial infections, plague, or something called Vibrio. And these are mostly ancient diseases. In modern times, we've had viral diseases like smallpox or HIV that have caused millions of deaths around the world, but they did so over many years. The respiratory viral diseases that have caused pandemics are shown here. And outside of the 1918 influenza pandemic that was called the Spanish flu that killed upwards of 50 million people on Earth, these influenza pandemics like the Asian flu in the 50s, and the Hong Kong flu in the 1960s, had about 1 million deaths over the time of that pandemic. And coronavirus, the COVID-19, has already killed more than 2.3 million people on Earth. So it is one of the deadliest respiratory virus pandemics that we've ever experienced. And the way we're going to get out of this eventually is by having more population immunity or community immunity. And I'm going to illustrate that here. When you have a population of people who are susceptible to infection, who are not immune, illustrated by this blue group, they are very susceptible to infection. They have high transmission rates, and that's the outcome. If there's an immune group with only a few susceptible people, you have much lower transmission, you have a lower force of infection, and you have much less mortality and severe disease. So this is a setting where you have a lot of severe disease. You can reduce it by getting an immune population. So how are we going to get immunity from this virus? Everybody, I think, is likely to have immunity from the virus within the next 3 to 5 years. And the question is, are you going to get that through infection, where we'll lose many people because of the severity of disease? Or are we going to get it through vaccination, which, as you know, does cause some side effects, but in the infection, you may have as much as 1 or 2% mortality and another 30% of people who have long-term symptoms. Whereas vaccination, there's maybe 2 to 3 people out of 1 million who have severe allergic reactions. So I think this is the choice that people have to make, and I hope we can share information that allows you to make that choice. Another thing that vaccination results in, I'm going to try to illustrate here with one group of people who have about 3 times more coronavirus in their community than this group down here. And after one round of infection, it might look like this, and another round, it might look like this. And then what if you overlay vaccination on top of that disparity, the starting disparity of about threefold. And let's say that the population with more virus has less vaccination than this population down here. And what will happen after one round is you go up to about 4 times disparity. And after another round, you go up to 6 or 10 times disparity. And so one of my greatest concerns that we face right now is, since we do have effective vaccinations, if there is a disparity in vaccine uptake or vaccine distribution, that the disparities we see now in people of color will grow over this next year. And that'll further erode the trust that people have in the biomedical research industry and the federal government. So Dr. Cotton did a great job of introducing coronavirus, so I won't have to say very much about this, but I'm just going to give you a few illustrations and images to help you see what we're doing and how we have been able to make this vaccine. And so here's a respiratory epithelial cell. These are cells that line your airway going down into your lung. And this is what beats the mucus out when you need to clear something from your lung. And this is a cell full of coronaviruses that are shown here coming out. Little spherical objects that have these knobs on the surface. And as Dr. Cotton already showed you, these knobs are the spike protein. And the spike protein is sitting on the virus. If this is the virus over on this side, and this is a cell of your airway over on this side, the spike protein is reaching out to interact with that protein, and then it rearranges itself to pull itself into the cell and start the replication process. So the goal of vaccination is really to show the immune system this spike protein ahead of time so it can make antibodies, which are other proteins in your body, that can block its function, either block attachment or block the rearrangement, or block it in some other way so that it doesn't work and the virus can no longer infect your cells. So this vaccine development process has gone very quickly, but it's because largely of the work that's been going on really for 20 years, more, not just 12 years as suggested here. And I'm just going to illustrate some of the things that have been done over these years. You may have heard about Dr. Kizzmekia Corbett, and I'm sure you would like to be seeing her today instead of me, but Dr. Corbett is a research fellow in my laboratory. We've worked together for almost 15 years now. She actually came to my lab when she was in high school. And over these last 5 or 6 years, she and other collaborators and academic sites around the country have done a lot of work to solve the structure and understand in very detail what the spike protein looks like, where antibodies need to bind to interfere with its function. And so we knew a lot about coronavirus before this outbreak. We also knew how to stabilize the protein in just the right shape, because as you could see, antibodies recognize shapes and surfaces. If you don't have the right shape of the protein, it's not going to give you the right kind of antibodies. And we learned a lot about this from working on other viruses like respiratory syncytial virus. We've also thought a lot and written a lot about ways to go fast and plan for pandemics, and not only work on ways of manufacturing quickly, but work on ways of planning around virus families and getting prototype preparedness, prototype pathogens done so that we would know what to do if the real thing ever happened. And then we've also had a lot of experience during this last decade in particular of responding quickly to public health emergencies of international concern, as we did in 2014 with Ebola and 2016 with Zika. So when this coronavirus was announced at the end of 2019 from China, we started preparing ourselves because it was potentially going to be a coronavirus. And we had already been working with a company named Moderna for 3 years using RNA in prototype pathogens, one for the paramyxovirus family and one for the coronavirus family. And we were using the MERS coronavirus for the coronavirus work, and Dr. Corbett and our small group working on that project had already tested mRNA vaccines for the MERS coronavirus in mice and shown that it could work. So we thought we knew how to make the protein, keep it in the right shape, and knew how to deliver it, which made all these events happen very quickly. We got into phase 1 studies within 65 days and into phase 3 studies within about 6 months. One of the byproducts of this kind of work is that once you know how to make the protein, you can share it with our other collaborators who are very good at identifying and discovering new antibodies. You can start with human cells from people who've recovered from the infection. So we did that with Epithelial and then worked with Lilly for manufacturing. And within 5 months of the time they got the protein and we found the antibody, that product for treatment was also in phase 3 studies. So this was very fast, and it was all based on knowing how to make the protein, knowing exactly what the shape of the protein is in order to have confidence that you can do, that it will do what you want it to do. And so we were able to use this protein to develop diagnostic assays with the CDC to discover this antibody I just mentioned, and also to launch a vaccine program with Moderna. But even these other groups that you've heard about in the US doing phase 3 trials like Pfizer, Novavax, and J&J are using this stabilized version of the protein that we had worked on these last 5 or 6 years. So the outcome of that phase 3 trial for Moderna, Moderna and Pfizer both started their phase 3 on the 27th of July. Pfizer came out about 1 week earlier, but by mid-November, we knew that both Pfizer, which is a vaccine that's almost identical to the one Moderna has made, and the Moderna mRNA, both of these mRNA vaccines had very good efficacy, meaning that they were very good at preventing symptomatic coronavirus disease or preventing COVID. I'm showing you the accumulation of infection events on this curve in the placebo group and very few infections accumulating in the RNA group. And there were a few infections here, but they were all mild and none of them required hospitalization. What you can also see here is that the first dose was given at day 0 and the second dose was given at day 28. And so you see that even before the second dose, there was quite a bit of protection. So you start getting protection even after 1 dose, and then it gets better and longer after the second dose. So overall, in the data the FDA had to evaluate, initially there was 196 infections and 185 were in the placebo group. And in the subgroups in the study, for instance, in the older group, there was also evidence that there was good efficacy of almost 90%. And in communities of color, of the 42 infections, 41 were in the placebo group and only 1 in the vaccine group. And of the people with severe disease, all 30 of those happened in people who did not get the vaccine. So on the 17th of December, this committee announced that they would approve this by a unanimous vote. And this committee, the VRBPAC, the Vaccine-Related Products Advisory Committee of the CDC, included a famous virologist from Michigan, Obetta Fuller, and my friend, Dr. Hildreth, who's the president of Meharry Medical College, was also on that committee. And the next day, the FDA gave it emergency use authorization. And just a few days later, Dr. Fauci, who I'm sure you all know, was vaccinated at NIH. And since then, a number of our colleagues and friends and and students have also been vaccinated. I think we're up to almost 35 million vaccinated people now. And this is Dr. Corbett receiving her vaccine. And I just want to tell you that even though now a lot of people are vaccinated and it's no longer entirely under study, the CDC still has ways of following safety over a longer period of time. And one system shown on the top, and it is what's called the VAERS system, Vaccine Adverse Event Reporting System. And it can be reported by either citizens or physicians reporting some adverse event you may experience. And during this rollout, the CDC's created another system called vSafe. It's an app on your phone that prompts you to report vaccine side effects and other problems you might experience with the vaccine. So these vaccines are still being monitored even though they're already authorized for use. And I just want to introduce the laboratory that I work with every day. Dr. Corbett's here, and she was leading this relatively small team of young students who've done a lot of the work on the coronavirus and helping Moderna to advance their product to this phase. So I will stop there and we can go to the questions.
Thank you so very much. We are asking, we do have some questions already, and this is for all of our panel members, but those of you that are still on the call, if you have any questions that you would like to ask, I would ask that you go ahead and put those in the chat box and we will get to those as quickly as we possibly can. The first question that I have, and these questions have come across and I got some prior to the meeting, will be for all of our speakers, but one of them coming out, and particularly for you, Dr. Graham, is that a lot of people are asking a question, and you actually covered it very well, is that there is a lot of mistrust because it seems like the vaccine just jumped up out of nowhere. And so especially in underserved communities, people are kind of wary of that. And the question that I have here is, how can we get the information in a format to our underserved populations? What would you suggest we do in getting this information out? Because a lot of that is not going forward. Of course, with social media, things are going forward that are not so much truth. They have a lot of myths in there. What would you suggest we do?
Right, it's a very complicated situation. And as you say, lies on the internet spread a lot faster than the truth. It takes a long time for the truth to catch up with all the lies. But the problem of vaccine hesitancy or lack of vaccine confidence in minority communities in particular is something that has both historical but also present day reasons. And I think that it's become well known that even in our healthcare settings today, that doctors and other healthcare providers are making decisions every day that involve bias, implicit bias, and there's structural racism and institutional racism that influences even decisions that are happening right now. And so the question is, why would groups that experience this decide to trust this time and take this vaccine? And it's not an easy answer to give. And honestly, one of the reasons I'm trying to give these kind of talks frequently is to help people at least have enough information to make their own decisions, and hope that because a lot of things have changed in terms of how this is all supervised, even though that doesn't help the implicit bias that goes on every day, that when people like Dr. Corbett are involved, and when people like me are involved, when my young African-American daughter is being involved in the Moderna trial and being immunized, and I trust the vaccine for her and she trusts me to take it, that we can eventually start bending the moral arc of the universe back toward the positive direction, and not and at least use this event to try to regain some trust in the system.
Thank you so much. My next question is going to go to Dr. Cotton. Dr. Cotton, being a physician here in the Mississippi area, one of the things that someone asked is that how do we know, the thing was to call your primary care physician. Is there a general mechanism where our primary care physicians are getting this information? You gave us access to the Department of Health information, but is there a general consensus of all of our providers that all of us see that where they're getting their information from, so we can basically be assured, because a lot of people will trust their primary care provider. Where are they getting their information from?
So just as Dr. Graham alluded, the hope is that we as physicians, we primarily follow CDC protocol, as well as our local health advisors, our health administrators protocol. And the information regarding the monoclonal antibodies that I spoke of is not a secret, but the hope is that most primary care physicians, if not all, are staying up to date with current recommendations, which would include, again, if you have a high-risk patient, high risk in the sense COVID positive, risky of a severe disease, then you may have that discussion about the monoclonal antibodies. But we know today the monoclonal antibodies are not being utilized, they're underutilized, particularly in the rural areas. They have been given to different hospitals all across the United States. The federal government has agreed to pick up the tab for the use of this therapy. And so I'm here today to we partner with our physicians for our care. So we also, hopefully have information about what to do with it, and then partner with our physicians to have that discussion. But the hope is that, yes, that it will be utilized more coming down the road as needed.
I think the other question, and to the second part of that question was, if it's available now, is it available in general, or do you have to go to the hospitals to get it, or do our primary care providers have access to it?
There are only certain hospitals that have it. And so for some of the larger hospitals actually have it, like in the Jackson area. I have patients that I treat who are in rural Mississippi, and I have had to send them like to the Baptist for this infusion. So they are offered in all of the states, but you do have to connect with the facility within your area that might have it.
Is that an outpatient infusion, or do they have to be admitted to the hospital?
They don't have to be admitted. No, it's outpatient therapy. These are patients. To qualify, the criteria is you cannot be hospitalized. You have to be a recently diagnosed COVID-19 that is being treated as an outpatient with high risk to develop severe problems from this disease. And so the hope is to give the infusion early in the course. And just like you have a chemotherapy infusion, so you can give it in the emergency room. I've had a patient who got it through the ER, or you can give it through those infusion centers that are set up in different hospitals.
Okay, thank you. I have a question for Dr. Wade, if you're still on the line. Dr. Ham?
I am here.
Thank you. Our question was, and this is regarding the development of class. The question was, is taking an aspirin sufficient blood thinner for outpatients if they are COVID positive? Is that something, should everybody be doing that, or is it appropriate for someone that's COVID positive to do that? Is that the appropriate thing to do?
That's not what we're recommending at this point in time. Once again, it's that inflammatory cascade that's associated with the virus that increases that person for the class. Plus, if they have a history of atherosclerosis. So if we're doing an aspirin a day, we're doing it because of the baseline history of atheroembolic disease associated with coronary artery disease. But as far as blood clots goes, like pulmonary emboli and DVT, that's not the treatment. That's the treatment's a different treatment. And then if I can go back and add to what Dr. Cotton was talking about the infusions that are done, I want to add that truly here in the greater Jackson area, all hospitals are offering the infusion, but it must be said that you have to meet the criteria for the infusion. One, you have to be at risk. Two, there's a certain time period that you have to present within before you can get the infusion. If you're a week and a half out, you're too far out and you won't get the infusion. It's a certain time period. So there's a questionnaire that has to be answered prior to receiving the infusion.
Okay, and that question should be directed towards primary care providers in order to get that process started?
Physicians, period. I mean, as a pulmonologist, I get phone calls from patients about it, and there's a questionnaire that we have to answer, go through with the patient, and then send the information over for the infusion.
Thank you, thank you. Dr. Graham, another question for you. The question was asked, if someone had the virus early on and someone had the virus in 2019, December 2019, do they still have antibodies? And that's one of the questions people are asking. Do I have antibodies on board? And if I do I still need to proceed with the injections, or am I already covered because I had COVID, because I was positive?
One of the interesting things we're learning is that in many cases, I think in most cases, the vaccine is giving better immunity than the viral infection. So the recommendation from the CDC and from others is that even if you've been infected with this coronavirus, after about 90 days or so, it would be in your best interest to also still get vaccinated. Because the vaccine would boost the immunity that may have been started by the infection, but the vaccine immunity may be better and longer lasting than the infection.
The other question is regarding vaccines, since we have you on the line, is that do we know yet any of the long-term complications of the vaccine? Because that's where a lot of the myths have come out. I've seen just some crazy stuff that people are thinking were long-term effects of the vaccine. Do we have as much as we know now, a consistent list of long-term side effects?
All the side effects that I'm aware of right now are more immediate. They usually happen within, at least within 7 days. And historically, more than 99% of vaccine reactions have happened within 6 weeks after the vaccination. And in the case of mRNA, it is a very simple, it's probably the simplest, most elemental vaccine that you could give to make a protein. It is just a single strand of this mRNA, which is something your body makes normally anyway. And it is very short-lived. So the mRNA that you're giving is only there for about 24 to 72 hours. The protein that it makes is only there for about 3 to 7 days, and then everything is gone. And so you can never say never, and you can never prove a negative, but it is unlikely that there is going to be a long-term side effect, and that most of the events are happening very close to the time of injection. And for mRNA, most of those side effects happen after the second dose. And my daughter just got her second dose yesterday. She doesn't feel too good today. She had little chills and muscle aches last night, and she's taken indomethacin this morning. And, she's happy about it because it means she's making an immune response, but she's also not too happy about it because she doesn't feel good today. And I'm expecting her to feel better tomorrow, but it is something you do have side effects after the second dose.
Okay, thank you. Back to Dr. Alexander, we do have a couple of questions for you. There's several questions regarding the vaccine, and we'll get to those, but we want to make sure that we're kind of comprehensive in what we've covered in the conference today. Dr. Alexander, are you still on the line?
I am.
All right. One of the questions is, what are the most common symptoms of heart attack in women? Because we know some of them are similar to men, but some of them are different. What are the common symptoms of heart disease in women?
Okay, so chest discomfort, if you're presenting with a heart attack or angina, is the most common. However, you can have neck discomfort. I'm talking about with exercise, or arm discomfort with exercise. But if you wake up in the middle of the night with some chest discomfort and you become sweaty, feel very weak, short of breath, those are symptoms of a heart attack. And you can have those same symptoms during the day. There are other symptoms of heart disease, like heart failure, where you have swelling in your legs, can't lie down flat, you got to sit up to breathe. And patients that have obstructive sleep apnea, they are also at risk.
Okay, your speaker went out for a sec. Okay, there you go.
I'm on my cell phone.
Okay.
But I'm okay. Go ahead.
No,
Was
we're
there
open.
any other?
Yes, ma'am. There's one more, and this is one that I've actually heard. Does apple cider vinegar clear up clogged arteries?
No, ma'am. That's all I got to say about that. And I tell my patients, if they thought that apple cider vinegar did that, don't you think that the pharmaceutical companies would put it in the pill and sell it? So, we just need to go with the science, like Dr. Graham talked about and some of the other physicians talked about. I don't know why our community are so reluctant to traditional medicine, but they will turn to alternative medications that have not been proven. So if we can just stick with what we have researched and we know works, and I promise you, you'll do much better.
What are some of those examples of some foods that do work, that are proven to work, that are readily available?
Okay, so foods that are, we recommend the Mediterranean diet as just a general diet. And that includes a lot more fruits and vegetables than you would normally get, say, in some of our diets. But high fruit and vegetables, low fat, a little bit of protein, about the size of your palm of your hand per meal is okay. Low sugar, low soft drinks, juices, all of those really need to avoid that. But increase your green vegetables, your colored vegetables like squash, broccoli, cauliflower, and you can fix them so they taste good. You just got to look at other recipes. But those are high in natural antioxidants.
Thank you. Thank you. One more question for Dr. Ham. With pulmonary health, one of the things, of course, obviously, hopefully everybody on the call knows about not smoking. That's one of the best things that we can do. But would you have any other suggestions as far as pulmonary health, the things that we can do as a baseline, whether we have any pulmonary issues or not, going from a perfectly healthy person, also incorporating people that actually have some pulmonary deficits? Are there some things that we could be doing? And the second part to the question is, what can we do as far as a daily practice in the age of COVID to maintain whatever our status is or to improve it?
Okay, I was on the phone, I'm sorry, because I'm on call. So I think I missed the entire question. I think that was addressed to me because I heard the word pulmonary. So can you please?
Yes. So the question was, what can we do for a pulmonary health status to maintain, to either improve where we are, some basic common things that we can do, either where we don't have any pulmonary issues or for people that may already have pre-existing things? What are some of the basic ABCs that we need to be doing on a daily basis? Sometimes we get to the higher end stuff and we forget the basic necessities of what I can do on a daily basis. And the second part was, in the age of COVID, doing the basic stuff. What other protective things, we know about the mask, but what other protective things that we can be doing to help ourselves to maintain our pulmonary health?
Okay, so this is really the same as it is for cardiovascular disease. I mean, they go together. The heart and the lungs really go together and work in sync with each other. So that what you do for heart health, you also do for pulmonary health. So good exercise. From our standpoint, the biggest issue is preventive care, meaning don't do things such as smoke, because smoking itself is a detriment to one's lung health and increases a person's risk for all types of infections, including coronavirus infection. If you have an underlying health issue with the lungs, such as asthma, know your numbers, know your symptoms, and take your medication as you should. And then, preventive wise, from a coronavirus standpoint, it's still it's wearing your mask, it's trying to stop putting your hands in your face, because you can get the virus through your mouth, your nose, and even your eyes. And so it's protect yourself, avoid the crowds. And it's the same thing that you would do from a heart standpoint. The healthy eating helps the heart, which actually helps the lungs. So they all go together.
And please speak to the people that we see in the public that have their nose outside of their mouth, outside of their mask. It is.
Well, what I tell my patients is this: you have a nose and you have a mouth, and they all get together back in the back posterior pharyngeal area that goes to the trachea. So the two objects meet together in the back. So we're supposed to be nose breathers more so than mouth breathers. The nose is there to try to help prevent us from getting infections by catching particles with the hair cells that we have in our nose. And so if your nose is out, you're actually still increasing your risk for getting it because you don't usually breathe through your mouth. So you're not doing yourself any good by covering your mouth and leaving your nose out.
Yeah, and I've actually started the habit that I will approach. I was like, your mask is slipped down a little bit, and most of the time, pretty much 98% of the time, people will say, okay, and they'll pull it up. So I just want to encourage all of us that as we see family, friends, or if you have a mask that's slipping down that much, you need to change that mask. You need a different mask if it does not stay above your nose. Another question, thank you, Dr. Ham. Question going back to Dr. Graham. The question was, like the flu vaccine is recommended every year, will the COVID vaccine, as far as we know of right now, have to be repeated after you get your either series of 2, or I know there's a new vaccine that's coming out that has 1. Right now, do we know whether or not we will have to repeat, or is there any information about that?
Right. First of all, just let me mention that there's a lot of links being put into the chat room that come from the Coronavirus Prevention Trials Network or from the CEAL, the Community Engagement Alliance, that can give you additional information that may not get to be answered on this call. So look in the chat. I also just wanted to mention something. I'm sorry not to get to the question right away, but the mRNA, people have been worried that it would cause infertility or somehow get into your DNA or do other things like this or interrupt pregnancy. I just want to mention that mRNA, it goes into the outside part of your cell. It never gets into the nucleus. The nucleus is where your chromosomes are, where your DNA is. mRNA only has to get into that outer part of the cell called the cytoplasm, and that's where the protein is made. So the mRNA never really goes into where your DNA is. And so it should not have anything to do with fertility or DNA or anything like that. And if you're worried about that, you're going to get a lot less RNA from the vaccine than you get from the virus infection. The RNA from the vaccine is only about 10% of what's in the virus. And if you get the virus infection, you're going to have it for a lot longer, a lot more RNA. So if that's what you're worried about, I would avoid the infection as much as possible.
Thank you. That was a lot of the questions I had. You took some off the plate.
Okay, and because I know people are worried about that. And the other thing is, even though pregnant women weren't enrolled in the trial, a lot of the early vaccines were given to healthcare providers. And a lot of those people are women, and a lot of them were pregnant. So there have been now almost 20,000 pregnant women vaccinated with these mRNA vaccines. And there have not been any adverse events that I have heard about. And so there's a lot of information that's going to be coming because those healthcare providers, even though there wasn't studies of it, they made a choice that the vaccine was safer for their pregnancy than getting an infection. And so there is a lot of data that will be coming out about that. Now, the durability, we don't know a lot about, but we do know the antibody levels last at least 6 months for the mRNA, and they've been very steady so far. The greater risk may be from some of these new viruses you may have heard about coming from the UK or South Africa or Brazil that are starting to change because every time the virus infects a new person, every time the virus changes, it has a chance to, every time it infects, it has a chance to change. And so to deal with that, we could make new vaccines or we could rapidly get everybody vaccinated and everybody protect themselves and everybody work together, since we're all in this together, to stop the spread of virus, to stop the new variants from coming up. So the durability question is going to have to be answered over time. I can't really give you a final answer on that.
Okay. Thank you. Dr. Graham, I'd like to ask a question because we are fast running out of time. Would you be open to sharing a contact email address for people that still have additional questions? Would you be open for folks to reach out to you after our conference today?
I'm very happy to answer questions as I can. Just be patient with me on email, because sometimes I lose big batches of it and need a reminder.
Okay, well, thank you. If you would share that, I'm sure we have that, so we will share that in the interest of time. And because this has been such a wonderful morning, we do want to say thank you to Dr. Graham, Dr. Alexander, Dr. Wade, Dr. Gordon, and also Dr. Cotton, as well as Xavier, for all of the great information, the wonderful fitness information that we've had. I am taking away a lot of information that I will use to spread to my community, to my family. And that's what we want to do, is a takeaway. And as a final input here for our program, we're about a few minutes away from 12, but we would not, dare not allow an opportunity for our president, Ms. Ella Jackson, to come on board, to come with some final remarks. And we do ask that if there are members that we did not, or attendees that we did not get to your questions, please put those in chat, especially for Dr. Graham, because he's not locally with us. And we will share a contact email address. And again, be patient, because he has a few things that are going on in his life right now that he has to take care of. So if you would put that information in the chat box. And now we would ask that Ms. Jackson, if you would come on and give us our final remarks and acknowledgements. And again, I just say thank you, thank you, thank you. It so far has been a wonderful morning.
It has been a magnificent morning. Am I unmuted? Are y'all hearing me? Am I unmuted?
Yes, we can hear you. We hear you.
Oh, marvelous. This has been a great day. Oh my, I'm clapping if nobody else is clapping. I have enjoyed this so much. And oh my, I'm just excited. Everybody's done such a great job. I want to just start out. I'm Ella Garner Jackson. I'm the founder and president of the Mississippi Congregational Network of Nurses and Advocates. And I want to just thank everybody for being here, all the presenters, all the participants. The highest number I saw was 170, and I'm really grateful for that. I want to thank, first of all, our program committee. You've seen people that are members of MCNNA here, but the two people you did not see who have done a great job and made sure that everything came together so that we could enjoy it has been Ms. Mary Harris and Ms. Erica Payne. They chaired this program committee. They kept us in line, and we're just grateful for them. And we're thankful for Jimmy Wells, who kept us on target today. And now let me tell you just a little bit. I'm going to read something about who MCNNA is. And I have to read it because I'm a person that talks. And if I start talking off the collar, I'll be on here by myself. Y'all will be gone. We are a group of people from faith communities. We're not just Baptists. We're Methodist, AME, Zion, non-denominational, interdenomination, Catholic, Presbyterian. We are people of faith. And our goal is to improve the overall health and well-being of individuals, families, communities, and we do this through screenings, individual health counseling, educational programs, linking individuals to community resources. And you saw that a lot of our speakers did that today. The questions was, how do I get a vaccine? And then how do I get the infusion? How do I get swabbed? That's a lot of what questions that we get. And so we have to have those so that we can keep our community healthy. We also do it through collaborating with other local, state, and national organizations, particularly around advocacy and providing access to healthcare. Advocacy is a big part of what we do. It's what we need here in our African American communities if we're going to serve the underserved. We're going to have to advocate so that some of the things that they need come to fruition. And so that leads me right into our speakers. These are our collaborators. Dr. Myrna Alexander, she had 2 programs last night. Then she was back here with us today. And that's who she is. She's a community person. She's an excellent physician. She's a woman of faith, and she's just great. But we have to have those collaborators. Maxie Gordon, psychiatrist. He may not answer a phone call when I call him twice about the same program, but he'll show up and do what he's supposed to do when he's supposed to do it. Dr. Joyce Way, she's a pulmonologist, but she's everything else. We call on her. She connects us with all kind of people to help us do what we need to do. One of the sponsors here was the links, the LaFleur's Bluff link, and you also saw where they're providing free mammograms for women who are at high risk. So they are here today to present, but they're with us year round to help us help people. Dr. R. Faith Cotton, I had the pleasure of meeting about a year ago, and she is on fire for the Lord. She is a community person, and she knows how to make things happen. And I'm so glad to be connected with her. And she has also another group that I'm a part of. They're called Followers of Faith. They are churches, and they have health and wellness ministries also. And we all work together so that the community at large can get what they need. Dr. Graham, oh, thank you so much for being here. We're so grateful. Thank you so much. And we want to thank the Association of Black Cardiologists who knew about our work, saw our work, and made the connection so that you could be here with us. Thank you. We're going to go back, share those links so that people can hear why this vaccine came about, as we saw pretty quickly, but not knowing that behind the scenes you've been working all along. I think that's going to help some people. Again, thank you, sir. And what else do I need to say? We talked about the Association of Black Cardiologists, the LaFleur's Bluff link. The Abundant Living Community Organization is an organization that works directly with MCNNA. Actually, MCNNA came out of the Abundant Living Community Organizations. It's the organization that helps some of the funding for the programs that MCNNA does, the Abundant Living Community Organization. Mississippi State Department of Health, Victor Sutton's group, has for the last 20 years helped Abundant Living so that we can provide training so that people can start health and wellness ministry and then join together with MCNNA to do the work. So we're joined at the hip. Then Followers of Faith with Dr. Cotton I talked about. Final word. We practice from a foundation of faith and well-being. It's the merger of the two. Dr. King said, of all the forms of inequality, injustice in healthcare or health is the most shocking and the most inhumane or inhuman because it often results in physical death. And we see this. We've always seen it. We really saw it in 2020 with all the other things that we had, health disparities, and then came COVID on top of that. So we need to be about the business of doing what we say we are. We say we're Christians, and John said, John 13:35, it says, by this shall all men know that we are God's disciples, Jesus' disciples, if you have love one for another. So Mississippi Congregational Network of Nurses and Advocates know that for we are God's handiwork. We're created in Christ Jesus to do good works, which God prepared from the foundation of the earth that we should do in advance. And so we ask for anybody who want to join with us, they're part of their health and wellness ministry, who wants to start a health and wellness ministry, who want to be trained to know how to lead a health and wellness ministry, to contact us, because we need all hands on deck. This thing is big. And I'm closing. And for the next 8 minutes, there's going to be a video. So if you want any contact information or names from the presenters, if you want to know how to join MCNNA, you'll have that opportunity. So I want to thank everybody again. We still have 140 people that didn't shut me out. So I'm going to shut myself out and we're going to look at the video. Thank y'all again. This has been marvelous. God bless you.
Good morning. My name is Valerie Tillman, and I'm a member of MCNNA. As you know, cardiovascular disease is the #1 killer of women in the United States, but too many women remain unaware. The more women know about heart disease, the better chance they have of beating it. Cardiovascular diseases, which include stroke, claims the life of a woman every 80 seconds. So join us, wear red, and help us to raise awareness of the #1 killer of women in the United States, cardiovascular disease.
Strokes kill more than 137,000 people a year.
On average, someone dies of stroke every 4 minutes.
About 40% of stroke death occurs in males and 60% in females.
For many women, a heart attack presents itself with symptoms other than crushing chest pain, such as indigestion and sweating, shortness of breath, tiredness and weakness, upset stomach and vomiting, and even unexplained anxiety.
Heart attack and strokes are life or death emergencies. If you think that you or someone you're with has any symptoms of a heart attack or stroke, dial 911 immediately. Remember, every second counts.
So what's your solution?
For start, we should lower our salt intake and cook and eat healthy.
Also, let's get on the move. Let's exercise, talk with your doctor about your blood pressure and cholesterol numbers.